if someone comes to me with a new algorithm and says, Brett, I think this could really help in the care of your pneumonia patients or your diabetic patients, the amount of due diligence I have to do because of the investment of time and resources to get that live in our system and using with patients is tremendous. There has to be a way that we can, I don't even know what the correct term is, platformatize. I just made one up right there, where I can have a platform that I've already vetted. I vet once, I vet annually, whatever it might be. I'm connected there and I can plug Andy's new diabetic algorithm in there, try it out for 3 months, see where my patients land. And if the data holds true for them, I'm just curious to your thoughts on just sort of this platform approach. And if there's other solutions to that from a technical perspective to get around it.
So I'm ignoring the argument between is it AI or is it complex rule processing?
Fair enough. Fair enough. That's fair. That's fair. Yeah.
Okay, but so I kind of ask you the question: what would you trust?
I would trust something that I could try. Let's say Andy Truscott's got a brand new platform, your company, and I connected to that. I vetted it. My relationship is with you and your company.
Yeah.
That's where the trust comes in. And then you have a basic level of vetting that you do with any company that comes with their machine learning algorithm, their AI, whatever it might be. And I still want to do my own vetting, but from a technical perspective, I don't have a new project. You do. You figured that out. And so my vetting from a clinical perspective can actually be done, whether it's in the background or live in production, with my own patients. Does that make sense?
Yeah, I understand what you're saying, but why would you want to vet something with production patients when you're trying to provide them the best care you can? This is still untrusted. You haven't proven it yet.
Yeah, I guess what I'm saying, I would run it on production patients, but in the background. It wouldn't be presented to clinicians.
And you have enough time to run things in parallel.
Correct. It's certainly better than doing a 6 to 9 month project only to find out this isn't working. I would like to have 3 months where I could easily connect. There really wasn't much of an IT project, determine that, yeah, this is great or this is not great, because it's with my own data. Does that make sense?
Yeah, I understand that point. The major question in my mind is actually providers who are able to run these things in parallel, okay? Because there is a time overhead from doing it, and that always causes me concern, because providers have more than enough things to do in their day without experimenting with the stuff that I've come up.
No. Yeah.
But something we are doing right now is, with one of the platforms we have at Accenture, our health and human insights indicators and models, we actually embedded inside it. So when you're cutting and slicing patient data, it shows you a diabetes score and a diabetes risk score. Okay, whether or not you ask for it, it's just sitting there in the corner. Yeah. And you can choose to pay attention just like you would any other clinical decision support. And I think that's probably a good approach for getting adoption of some of these new quote unquote AI type algorithms. Is actually, there are existing clinical decision support channels out there. Okay? There are existing ways by which we can display risk information around patients on whatever dimension. And we are trying to develop new ones as well around, especially things like social determinants of health, but also around other clinical risk, etc., as new models come out. So augmenting that, but making it more accessible. And there's some great examples from around the world in that kind of risk data is made more accessible.